And with this, I'm gonna end by introducing Dr. Lorenzo Rinaldo. So you're gonna give the introduction? All right. So first, we would like to present you with a, okay. So this is on behalf of the department. This is a plaque to thank you for participating in our visiting professorship. And so let's come here. Thank you.
Thank you very much, Dr. Tuck. It is truly an honor to present today's keynote speaker and visiting professor, Dr. Rinaldo. Dr. Rinaldo is an assistant professor of neurosurgery in the Department of Mayo Clinic, Rochester. In 2015, Dr. Rinaldo received his MD PhD degree from the University of Chicago School of Medicine, PhD in neurobiology, with his thesis named The Control of Synaptic Plasticity in the Cerebellar Cortex by Cholinergic Signaling. Dr. Rinaldo completed neurosurgery residency in 2022 in Mayo Clinic, Rochester, with an unfolded neurovascular and neurosurgical skull-based oncology fellowships. In 2023, Dr. Rinaldo finished a cerebrovascular open and endovascular fellowship in UCSF. Throughout his career, Dr. Rinaldo has been the recipient of numerous prestigious honors and awards, including the Outstanding Performance Neurobiology Award in 2014, the 2014 Naomi Raggins Goldsmith Career Development Award, the David Piepkras Award in Excellence of Neurosurgery Mayo Clinic in 2022, among others. Dr. Rinaldo's scholarly contributions have made an impact in the realm of neurosurgery, and here are just some of his recent publications. Dr. Rinaldo has an outstanding academic background as evidenced by an H-index of 17 in Scopus with more than 900 citations. Once again, it is an honor to have Dr. Rinaldo with us this morning. Thank you very much.
And also, Dr. Rinaldo, if you allow me, before you continue with your great talk, I would like to acknowledge the great participation that we have from all over the world. So we have around 45 virtual participants from 8 different countries, including Colombia, Dominican Republic, Spain, Mexico, Italy, Panama, Thailand, and multiple states in the US. Thank you.
Thank you very much. Very kind introduction. I just finished training and I'm already a visiting professor, so it feels pretty good, but thank you for that. And to advance these, yeah. So today I'll be talking about the topic that's been of interest to me since I was a resident, determining optimal treatment strategies for ischemic Moyamoya disease, specifically choosing between direct and indirect revascularization. I don't have any relevant disclosures. So in general, I'll give a brief overview of Moyamoya disease, just some basic information. I'll review both indirect and direct revascularization techniques. I'll talk about some criteria we can use to select treatment with a focus on preoperative imaging findings as well as measurements of intraoperative flow. And then I'll give a couple cases. So Moyamoya disease, as I'm sure you are all familiar, it's an idiopathic steno-occlusive disease that affects the supraclinoid internal carotid arteries and the associated major branches. And there's a compensatory formation of collateral Moyamoya vessels, which are generally hypertrophied lenticulostriate arteries at the skull base. It's a rare condition, more common in Asian populations, less so in Western populations, but regardless of ethnicity, there's a 2-to-1 female to male distribution and a bimodal age distribution with peaks in the 1st and 5th decades. And the most common presenting symptom is cerebral ischemia, followed by intracranial hemorrhage, which is more common and much more common in adults than pediatric patients. Moyamoya disease was first described in the 1950s, but the term Moyamoya was coined in the 1960s by Dr. Suzuki. He also proposed an angiographic grading system that describes the progression of the disease, and the stages are here on the left. It's probably better understood by looking at the representative images. This is a normal angiogram. This is early on in the disease where you have tapering of the supraclinoid internal carotid artery. This is a fetal posterior cerebral artery here. As the stenoses progress, you have associated formation of the Moyamoya vasculature at the skull base, and eventually the carotid artery becomes occluded and the Moyamoya vessels involute, and the intracranial circulation is supplied either entirely by the posterior circulation or the extracranial vasculature. So the natural history of Moyamoya disease is generally progressive and characterized by recurrent events. The nature of recurrent symptoms is typically influenced by the symptoms at initial presentation. So patients with ischemia present with ischemia, those with hemorrhage tend to present with recurrent hemorrhage. The recurrence rate of stroke is pretty high, can be or has been estimated to be as high as 65% in 5 years in some populations. More recent studies put the annual risk somewhat lower, somewhere between 1.5 and 3%. Patients with hemorrhage tend to have a higher risk of recurrent hemorrhage, which probably reflects the severity of their disease. The treatment is primarily surgical, consists of revascularization surgery. And the idea is to reduce neurologic events by increasing cerebral perfusion. So the mechanism for patients with ischemia is obvious. You increase blood flow, so you reduce the risk of stroke. For patients with hemorrhage, the thought is we can take pressure off those fragile collateral vessels that are likely to bleed, and thereby reduce the risk of subsequent hemorrhage. There's two main types of surgery, indirect and direct revascularization. The indirect surgery involves the apposition of some vascularized tissue, either the superficial temporal artery, a dura temporalis muscle to the brain surface with a gradual ingrowth of collateral vessels. And this is in contrast to a direct revascularization, which involves an anastomosis between an extracranial donor vessel, typically the STA, and a cortical recipient, usually an M4 branch of the middle cerebral artery. And in current practice, direct surgery is often combined with some form of indirect revascularization. These are just some examples of indirect revascularization in general. The STA is dissected free of adventitial tissue and then ultimately placed on the brain surface, then termed an arteriosyngiosis. This can be combined with inverting the dural leaflets, dural syngiosis, or placement of a temporalis muscle on the brain surface, a myosyngiosis. And if you combine all of them, you can get an encephalodural arteriomyosyngiosis. And this, again, pretty basic stuff. Direct revascularization involves the enticide, usually an anastomosis between the STA and an M4 recipient. And as I mentioned, it can be performed either in isolation or combined with some form of indirect. Here we see a myosyngiosis performed with it. So what are some of the advantages and disadvantages of each one? The obvious one is with direct surgery, you get an immediate increase in perfusion pressure. And that's depicted in these graphs here. So after the bypass, you have an immediate increase in flow, and that actually continues to increase as the graft matures. This is in contrast to indirect revascularization, where you have a latency period prior to formation of these collateral vessels, where patients may still be at risk of ischemia. And usually this is 3 to 6 months after surgery that we start to see these vessels form. So how long exactly does it take? It's variable and depends on a number of factors. So this is a study from children looking at the time to being free from further ischemic events. And while there was a mean of 239 days after surgery, it's pretty highly variable when that freedom occurred. And this is a radiographic study looking at serial MR angiography, and they found that collaterals start to form around 1 month, and they intensify and ultimately plateau somewhere between 3 and 6 months. It should be emphasized that in children, indirect collateral formation is usually robust, so much so that that is the standard of care in that population. That's not necessarily the case in adults. This was a study comparing indirect and direct surgery in adults and pediatric patients. They looked at the degree of revascularization, so how much the graft supplied the MCA territory. And whereas in children, which are the gray bars, indirect surgery and myosyngiosis consistently resulted in a high grade of revascularization. That was not the case in adults, and they tended to benefit more from a direct revascularization. So what are some disadvantages of doing a direct surgery? One, it's technically more demanding. It's not always possible. It's dependent on a suitable donor and recipient being present. The incidence is reportedly low, but you risk occlusion of the graft immediately after surgery or in a delayed fashion. And if you didn't combine your surgery with an indirect surgery, the patient can be left with little or no benefit from surgery. The literature is variable, but there is probably an increased incidence of complications after direct surgery, both ischemic and hemorrhagic. And there's also a risk of hyperperfusion syndrome, which is often associated with transient neurologic deficits. And the incidence, again, is variable, but may be as high as a third of patients. And rarely, it can result in hemorrhage, which is rare, but when it does occur, can be devastating. So there's been numerous meta-analyses looking at this question. This question seems tailor-made for meta-analyses, looking at both angiographic, functional outcomes after both surgeries, the incidence of complications, and there's very conflicting data. So this was a meta-analysis of meta-analyses, and won't go through each study, but in general, there seems to be a trend towards improved outcomes after combined direct and indirect revascularization surgery. This is in adult patients with ischemic disease. There's probably a higher incidence of complications after direct surgery, but there's a lower incidence of delayed events, which makes sense because you would expect a higher risk in the latency period after indirect surgery alone, where patients may still be at risk of ischemia. So how can we choose? Should it be standardized or on a case-by-case basis? If it's the latter, the two most important criteria would seem to be one, an assessment of perioperative risk, how much risk is there for an event during surgery, and two, the urgency of need. So how likely is a patient to have a stroke in the latency period after indirect surgery? And this is a vast oversimplification, but in general, a higher amount of perioperative risk would favor an indirect surgery, whereas higher urgency of need would favor a direct approach. And in clinical practice, these algorithms will conflict, in which case it's helpful to have as many objective criteria as possible to choose the appropriate treatment. So I'll start with a discussion of perioperative risk stratification. Historically, the Suzuki grade has been used, but it's consistently been shown not to correlate either with disease progression or with risk of perioperative events. And that's probably because it's based just on angiographic characteristics. Another scale that I've found useful is the Berlin grading scale. It's a composite grading system that incorporates not only angiographic features, but also a history of ischemia, as well as an assessment of impairment of cerebrovascular reserve. So this is just the components of the scale. You get points if you have evidence of prior ischemia, acute or chronic. This is angiography. You get a point for high-grade stenosis or occlusion. If there are intracranial to intracranial collaterals, shown here, there's a parieto-occipital collateral to the MCA territory, a posterior splenial collateral to the ACA territory. If those are present, you get 2 points, and you get 3 points if you have extracranial to intracranial collaterals. And finally, you get 1 or 2 points depending on the severity of impairment in cerebrovascular reserve. And I'll talk about this in more detail. Basically, the more points you have, the higher your grade, which is 1, 2, or 3. And this scale has been consistently shown to correlate both with the incidence of perioperative events as well as long-term outcome after surgery. So despite having a similar baseline preoperative status in the long term, patients with more severe disease tended to do worse. So it's a bit outside the scope of this talk, but this is actually an argument for early revascularization prior to patients, prior to the disease progressing, as patients with less severe disease tend to do better in the long term. So there's obvious limitations to relying solely on an assessment of perioperative risk. While low or higher perioperative risk would favor indirect surgery, it's likely that the highest risk patients are also the most likely to benefit from an immediate increase in perfusion pressure. So we should combine perioperative risk stratification with an assessment of risk of events in the short term after surgery. And to do that, we can use both imaging findings before surgery as well as some intraoperative findings, mainly flow measurements, to determine how necessary or how likely a direct bypass is to succeed. So I'll start by talking about cerebrovascular reserve. There's multiple definitions, but in general, it's a measure of the vascular response to vasoactive stimuli. And this underlies the phenomenon of neurovascular coupling, which is an increase in blood supply to activated brain areas. In Moyamoya disease, the arterioles distal to the stenosis are often maximally dilated. So they're not able to dilate further, and this inhibits neurovascular coupling. When this is present, that's termed impaired cerebrovascular reserve. And when this is present, it's been associated with a higher risk of stroke in the follow-up period. This is just an example of that. This is a study looking at conservatively managed patients with Moyamoya disease, and you can see the cumulative incidence of stroke over time, which highlights the progressive nature of the disease. But if you stratify patients by whether or not cerebrovascular reserve impairments are present, you can see there's a clear difference. Patients without that radiographic finding have a much lower risk of events during follow-up. I'll just talk briefly about how we measure cerebrovascular reserve. There's multiple ways to do it. We use a functional MRI coupled with a vasoactive stimulus, which is a breath hold. And this depends on the detection of BOLD or blood oxygen level dependent signal. So after a vasoactive stimulus, which is a breath hold, you have increase in partial pressure of carbon dioxide, leads to vasodilation and increased oxygen delivery. This results in a relative decrease in deoxyhemoglobin, and this manifests as an increase in T2 weighted signal intensity. And that is the BOLD signal. So areas without an increase in BOLD signal after that stimulus have impaired cerebrovascular reserve. And if there's a reduction in signal, it indicates a steal phenomenon. So blood is being shunted away from the brain areas in question to areas with intact reactivity. And we often combine this in a single setting with parenchymal imaging, other perfusion studies, and vessel wall imaging to make a kind of one-stop shop for patients so they don't have to come back for multiple studies. So this is just an example of the output. So this patient with Moyamoya disease, you can see absent BOLD signal, which is indicated by the orange in both hemispheres and prominent areas of steal in the watershed territories. And over here, this is a different patient without cerebrovascular disease, and this is what normal should look like. You have diffusely increased BOLD signal, suggesting intact cerebrovascular reactivity. So you can clearly see a difference here. So how can we use this information to select treatment? When cerebrovascular reserve is improved, it's been consistently correlated with freedom from future ischemic events. This was a study comparing direct and indirect revascularization and found in the follow-up period lower incidence of ischemic events after direct relative to indirect surgery. And this correlated with an improvement in cerebrovascular reserve, suggesting that if you have a significant reserve deficit, patients may be more likely to benefit from direct surgery as opposed to indirect. Another modality we can use is vessel wall imaging, which is a high resolution MRI aimed at looking at enhancement patterns in the vessel wall. For Moyamoya disease, the typical enhancement pattern is concentric, and it can be either absent or moderate. It's usually not very intense, in tandem with negative remodeling, which is a reduction in outer wall diameter. So these are just some representative changes in different forms of cerebrovascular disease. For Moyamoya disease, you have a circumferential thickening, which manifests as circumferential enhancement, in tandem with a reduction in outer wall diameter. And this is in comparison to some other forms, a common one that's often not necessarily confused with Moyamoya disease, but there's equivocation on what the diagnosis is. But intracranial atherosclerosis, you can see for that condition, there's usually eccentric enhancement in the area of the plaque with positive remodeling. So Moyamoya disease, because of these, or excuse me, vessel wall imaging, because of these pretty consistent findings, it's been very helpful in differentiating Moyamoya disease from other forms of cerebrovascular pathology. Can we use it to select treatment? Possibly. Vessel wall enhancement, just because it's not always present, it can be absent in patients with Moyamoya disease, has been found to predict disease progression. Whoops. This was a patient at our institution. This was her initial vessel wall imaging study just 6 months after she initially presented. You can see concentric enhancement and negative remodeling affecting both ICAs and the right A1 segment. You can see kind of spreading of the enhancement at 12 months, and then by 18 months, the vessel had completely occluded. And this is her serial angiography initial study showing stenosis of the terminal ICA and proximal M1 and A1. And you can see on the follow-up, the ICA completely occluded. And this is just her PCA. In general, the pattern seems to be that enhancement precedes progression of stenosis. And when the stenosis occludes or leads to occlusion, you have a reduction in enhancement with a relative period of quiescence afterwards. And this has been shown in multiple studies. This is showing a similar result. Enhancement precedes progression of disease. And it's also been found to predict the incidence of stroke in the territory of the affected vessel. So all of this suggests that if you have robust enhancement, that may be more active disease, more likely for stroke in the near future, maybe more likely to benefit from direct revascularization. So I'll transition to some intraoperative measurements. The main one is flow measurements, the normal flow in an M4 branch, which is the typical recipient, is about 12 to 18 cc's per minute. In a study of patients with chronic ischemia, the M4 flow is measured to be significantly lower between this range. This included a small number of Moyamoya disease patients, and in these patients in particular, flow tended to be reversed in the M4, so going retrograde. So how can we use that information to select treatment? One study that did so was from Stanford, Dr. Steinberg's group. They reported the results of an individualized treatment selection strategy using the presence or absence of 4 criteria. The first criteria was severe stenosis. Second was impaired cerebrovascular reserve or STEEL. Third was history of frequent TIAs or stroke. And finally, the measured flow in the M4 recipient of less than 8 cc's per minute, or retrograde flow. And if any of these criteria were present, they proceeded with direct surgery, so somewhat low threshold for doing so. But when they applied those criteria, they found no difference in functional outcomes between direct and indirect surgery, suggesting treatments were appropriately selected, and a higher degree of revascularization after direct surgery. So the graft would supply a greater proportion of the MCA territory. And you can interpret that in multiple ways, but one way is that when these conditions are met, there's sufficient demand for the graft, allowing it to mature over time and supply a greater proportion of the MCA territory. I'll just talk briefly about how flow is measured. This is the Charbel flow probe. You probably have already seen this or use it here. It's a disposable probe, and you place the vessel in this little notch, and it gives you a real-time measurement of flow in cc's per minute. This probe allows the measurement of the cut flow, which is a concept introduced by Dr. Charbel and Hanjani. Basically, it's the flow through the cut end of the STA, and it represents the maximum possible flow through the STA as the pressure gradients between proximal and distal, which is basically a sink, have been maximized. And after you perform the anastomosis, you can calculate the cut flow index, which is just the ratio of flow through the STA after the anastomosis to the cut flow. So it's basically a measure of how close you are to the maximal possible flow with your bypass. And the closer you are to 1, it's been correlated both with long-term patency of the bypass as well as the degree of revascularization. Another question I found interesting is whether or not it's important to reverse flow in the recipient artery after or with your anastomosis. This study from 2019 found that when you reverse flow in the recipient, it correlates with flow in the bypass measured postoperatively. Just give a picture to show what I mean. So this is before the anastomosis, and this is normal anterograde flow in the M4 vessel. This is after the anastomosis, and you can have flow reversal, which means you have both retrograde and anterograde flow in the vessel, or you just have persistent anterograde flow, which is no reversal. And they found that if your cut flow was above 28 cc's per minute and you approached 1 with your cut flow index, you almost always reversed flow. They didn't address it specifically, but I imagine the ability to do this is also dependent on the baseline flow through the M4 vessel. So I'll just talk about a few cases. This was a 51-year-old female initially presented a decade ago with headache, encephalopathy, and expressive aphasia. Was actually thought to have some form of intracranial vasculitis at first, but her disease quieted down, but over time she nevertheless had stepwise worsening of her aphasia, but had been stable since 2019 on dual antiplatelet therapy. When she presented to me, she had been having repeated episodes of transient right-sided facial droop. Her exam, she did have some moderate expressive aphasia, but was nevertheless able to communicate with her husband very well, but otherwise had no focal neurologic deficits. And this is just showing her MRIs over time. And you can see by the time she presented us a fair amount of ischemia in the left MCA territory, but no acute ischemia on her current presentation. This was her angiogram from 2013, somewhat equivocal picture, likely some tapering of the distal supraclinoid ICA. This is most recent angiogram, progression of stenosis, also with some possible Moyamoya vasculature at the skull base. And then she did have some leptomeningeal collaterals from the ACA territory as well. This is the right side in 2013, essentially a normal angiogram. In 2023, had stenosis isolated to the A1 segment here. This was her vessel wall imaging, fairly concentric enhancement in the terminal ICA and M1 segment with negative remodeling, and also enhancement in that right A1 segment, which was the one affected on the right side. And this pattern was felt to be most consistent with Moyamoya disease. This was just a CT perfusion showing an expected perfusion deficit in the left hemisphere. We didn't have a measure of cerebrovascular reserve in this patient, unfortunately. So for her, we thought she needed treatment. We didn't have a measure of reserve, but possibly high grade, so high risk of perioperative complications. Her vessel wall imaging did show enhancement, suggesting active disease. She did have a lot of prior infarctions, a high volume of infarcted territory on the left side, but no recent infarcts on her MRI. So with her, given how many strokes she had had on the left side, we were worried about hyperperfusion related hemorrhage. So we selected an indirect approach for her. And this is just a video really just to show the basics of the technique. So as I mentioned, the STA is dissected free of the tissue. That's just being shown here. So pretty standard techniques. For indirect procedures, try to harvest a longer segment, about 11 or 12 centimeters, just to have a longer segment resting on the brain surface. after the craniotomy, we open the arachnoid diffusely and try to lay the vessel in a sulcus. This is just more of that, which I can probably skip through some of this. It's just opening more arachnoid. Oops. Yeah, it's not really doing much. If I go forward or back, it's just. Sorry. No.
I noticed that you're doing the SPA, what I call naked, so you're not really soft push.
Mhm. I have found that when you don't do that, I think one of the benefits to that is that it relaxes the vessel. So in a sense, you get more length. I'd always seen in training when we did indirect procedures and there was a cuff, sometimes it'd be hard to get the vessel to lay down on the brain surface. I imagine, that's partially because you release CSF, the brain relaxes and falls away. When it comes back, you'll get better apposition. But I liked it. Really lets me kind of put the vessel down in the sulcus just because I have a relaxed vessel. That's the rationale. I don't know if it's been studied whether or not the lack of that adventitial tissue affects the ingrowth of vessels. I'm not sure. I'd be happy to hear your thoughts.
Yeah, I mean, I there's so many techniques for bypass, to be honest, to the point where it's a little bit confusing to decide on what to use and what the response is. But yeah, I don't have, but I just noticed that this is, yes, a Japanese school style. I mean, looking at your videos, this is the Japanese school of bypass.
I watched a lot of
which I'm not
YouTube
sure where you
videos.
got from your training in Rochester, because that's not what Fred Meyer used, and I don't know if Adib belongs to the Barrow. That's not what they use. But,
yeah, I always just I like that technique just because it's very hemostatic, and I feel like it's, for me anyways, it was faster. And I always thought that some of the traditional methods of dissecting the vessels was the most stressful part of the case. I was always worried about injuring it. This technique is pretty safe. I was worried that initially it would kind of burn the vessel, but that's never really been an issue. I think it works pretty well.
great. So let's hope to finish the video.
Try again to maybe skip some of this stuff, but yeah, oh boy. Go past it before it freaks out.
Let's the video run. Then you try to stop. Step.
So while waiting on the video, let's talk a little bit more about direct and indirect. What is your indirect with those? So we see the direct. What is your indirect strategy with it?
Well, my indirect, I kind of put everything on there. I invert the dura, I put the muscle, I put the vessel.
You
just
also
to have,
put the muscle.
I do. It definitely has a consequence in a sense. The patients do complain of pain when they chew and things like that. But I do think it's worth it. I always thought that the dural leaflets, I was never impressed by dural leaflets. They just was never convinced that it was gonna work as much. So I always feel like I like to put the muscle down.
Let's see if other people have questions while waiting for the videos. What are your thoughts on parietal frontal subdivision? How you decide?
Usually, I just pick the parietal branch if I can. Just allows a linear incision. I don't really have a, if there's a prominent frontal branch, obviously, if it's markedly different in caliber, I'll try to do that. But I don't, I like the small linear incision over the parietal branch, which is, posterior. That's my preference.
Wonderful. Let's see this time if we're lucky.
I
for
think
the
we'll
video.
just skip it. It's really pretty standard after that. It just shows laying the vessel on the brain surface. And this was just a post-operative scan showing patency of the vessel over the brain. And she ultimately did okay and discharged home after a couple days. I don't have follow-up, still pretty early on in my practice, but she'll come back for an MRI and ultimately another angiogram at 6 months. This was another case, challenging case from early in my practice. This was a 41-year-old female presented with recurrent left-sided infarcts causing a right-sided weakness. When she presented to me, she was neurologically intact. This is her prior MR. Showed ischemia in the deep white matter on both sides, more on the left than the right. This was her angiogram, and you can see tapering of the distal ICA here and flow limitation in the MCA territory, no filling of the ACA territory. She had some leptomeningeal collaterals from the parietal occipital arteries. So right side, some tapering here as well, not as pronounced as the left side. She also had some cross filling over the anterior communicating artery to feed the left side. But she also had some intracranial to intracranial collateral suggesting some flow deficit in the MCA territory. Her vessel wall imaging was somewhat atypical in that it was more of an eccentric enhancement pattern, but she did have negative remodeling, and this again was thought to be most consistent with Moyamoya disease. She had bilateral perfusion deficits and fairly diffuse impairments in cerebrovascular reserve with some steel in the posterior watershed territories. So given she had pretty severe disease at Berlin grade 3, she had pretty significant impairments in cerebrovascular reserve with steel. So for her, we kind of planned to do direct revascularization on both sides. And we started with the left, which was her symptomatic side. And that procedure was uneventful. We didn't do flow measurements in this case. This was early on, one of the first revascularization cases that I did. So I wasn't using the flow probe yet. And this was just her post-operative CTA showing patency of the STA. She initially did well and discharged home, but 2 weeks later, she had an episode of hand weakness. So we brought her in for imaging. She had new infarcts, mainly on the right, but also some scattered infarcts on the left. This was her CTA showing the graft was still patent. And the left-sided infarcts I ascribed to the fact that both ACA territories were fed from the right side. So it seemed that she was clearly symptomatic on the right as well. We didn't do surgery immediately. We waited about 4 weeks or so before proceeding with surgery just to let her cool down. And then we did a plan to do another combined surgery on the right. This is just a video of that. Again, a dissection of the STA. And she really only had one possible recipient shown here. We started with ICG just to get a sense of the direction of flow. It was anterograde from left to right here. After that, we measured flow in this vessel. And this was pretty low at only 2.5 cc's per minute. And then this is just showing measurement of the cut flow. So you cut the STA, and then you basically remove the temporary clip proximally and let the flow go. And then you measure it. And this came out to be about 32 cc's per minute. And then this again is just standard fish mouthing of the vessel in preparation of the anastomosis. Lining up the recipient and the donor, and this is the arteriotomy. And then this is just, the end to side anastomosis, again, pretty standard techniques. Then we release the clamps. And then ultimately we'll measure flow through this. And the measured flow was about 35 cc's, so more or less a cut flow index of 1. And then I found interesting was flow was now reversed in this vessel. It's now going right to left, retrograde. And we ended up doing angiography post-op, showing pretty good revascularization of the MCA territory. So she initially did well, but did develop some new hand weakness on post-op day 2. This was her initial CTA showing patency of both grafts. So after the development of that hand weakness, we did some imaging studies. She had some pretty significant increase in blood flow on the right side. So we were thinking this is possibly a hyperperfusion syndrome. Also likely did have a small infarct in that side. Hard to say which was causing the symptoms. The delayed onset made me think more likely a hyperperfusion, but hard to say. More concerning though, so this was her initial CTA. On the postoperative day 2 CTA, the contralateral graft had actually gone on to occlude. So at this point, we took her for angiography. This is again the right ECA injection showing the supply of the right STA to the MCA territory. And the anastomosis is here, and again, flow is retrograde. And then anterograde from the MCA bifurcation. So whether or not, if you achieve this, will this consistently result in greater degrees of revascularization? It's tough to know, but something worth looking into. This is the right ICA, and the only thing that's really different here, whereas previous, should stop messing with it. Basically, the degree of cross flow had significantly increased, whereas the right ICA previously supplied predominantly the right MCA territory. It was now mostly crossing over to the other side.
So, in some of those patients that you just showed, they have a very active disease that's going on. And as you see here, what you were trying to show is that now there is competitive flow to the other bypass.
Yeah.
Coming from the contralateral side, which was not the case when you started.
Yeah.
And when you put this bypass, and this highlights the changes, the active changes on those cases. And sometimes you do see some improvement, but when there is improvement, my tendency was that seeing those patients are more vasculitis than the Moyamoya idiopathic. What's your sense on vasculitis being a component of those, and some of those cases being vasculitis? How you sort it out?
I mean, I think the clinical presentation, when, it's not, I think of vasculitis as kind of a more fulminant process. Patients are encephalopathic, bad headache. It may be a component of that, but it's hard to know what to do with that information and how that influences management. So if you suspect a vasculitis component, I guess, how does that influence how you manage them?
Yeah, I'm not talking about the vasculitis that we see, the fully blown syndrome, but it looks like to me some of those patients have an inflammation on one of those vessels. And that inflammation might not be the typical textbook picture of vasculitis bilateral and acute syndrome, basically. My theory on those is that there is some sort of, just like mononeuritis, multiplex, and I mean, I get lost in those terminologies with neurology, how one nerve is inflamed versus all nerves. I think there is a process similar to this in brain vessels where, the typical vasculitis versus a local inflammation on one of those vessels.
Yeah.
Typically, the Moyamoya, there is no inflammatory cells if you take the vessel to pathology, but some of those, the insult is viral injury to the vessel or some sort of autoimmune or something, and they end up getting into the classification of Moyamoya.
Yeah.
And this is a very good example, an eye-opener case that yes, it resolved, and now you have competitive flow. And that these are the patients that I'm talking about, which don't fit the typical criteria for evolution of Moyamoya, and they don't fit the typical vasculitis. There should be something,
I think that's honestly probably, if not the majority, close to it in the Midwest population. I know Fred Meyer published a paper looking at the prevalence of autoimmune disease in Midwestern patients with Moyamoya disease, and it was significantly higher than in other populations. So it seems like not quite the same disease as the classic Moyamoya in Asian populations, for example. I don't feel like we really see the robust Moyamoya vessels either, whereas you see them in other populations. So I agree. I do think there's differences going on. This was just so we did an ECA injection on the left, confirming occlusion of the bypass, and not really any significant formation of collaterals. And her contralateral ICA had actually gone on to occlude between now and her prior surgery. This is just for comparison, showing that before surgery, her MCA was still filling from the ICA injection. So just like you mentioned, the reason for this had to be now competitive flow in the setting of a contralateral bypass. And something like this has been reported. It's mostly been contralateral ICA occlusion, which we also saw here, not necessarily occlusion of a contralateral bypass. Could this have been prevented? Tough to say. She did have that abnormal configuration with cross-flow over the ACOM before surgery, which maybe was a setup for something like this. Though I don't think, even in retrospect, hard to say I would have done anything differently, given, you know, her recent strokes and the low flow that was measured in her M4 vessels. This is just comparing her pre and post-operative perfusion studies, and it's a bit apples to oranges, but maybe slightly better on the right side, probably about the same on the left. And she did okay. Her hand weakness improved, not back to baseline, but did get significantly better. And ultimately, she discharged to rehab. And we'll bring her back in 6 weeks for more perfusion studies, which should be coming up pretty shortly. And then we'll do another angiogram at 6 months. So future directions, really just want to continue to correlate both pre and intraoperative findings with outcomes of both indirect and direct revascularization, and try to find treatment-specific predictors of both complications and the degree of revascularization. So that's all I have. I'm happy to take more questions.
A great presentation on a very difficult topic that, I mean, talking about bypass, whether, you know, it's just a wonderful mastery art technique that I think we're still, as a neurosurgery group, struggling to find indications, but this is the persistent indication across that it is a good technique, and that's the right thing for bypass. So how do you sort out the Moyamoya? So what are you thinking on so you mentioned about the parietal division. You mentioned about dura and muscle. You do all things, all of them together. What should we do different for those cases? Okay, so what is it? Early, late? What do you think, or what would you like to see changing for care of Moyamoya?
I think from what I've seen in training, there's not too many ways to determine if a bypass is going to turn into this really mature graft. It kind of happens or it doesn't happen. And I think there's maybe ways to suss that out. Should we, you know, which recipient do we choose? If there's multiple recipients, what's the flow in each possible recipient? How do we orient the graft to maybe promote it flowing retrograde and then anterograde to supply a greater amount of the territory? You know, what can we do? And also identifying conditions where, you know what, this is a setup for this bypass to not work and not mature. So if we can find those, we can really fine tune the selection of doing a direct bypass, and maybe only do it when it's really going to work and it's really necessary. I think that's what I'd like to work on.
Wonderful. Other questions? All right.
Well, thanks very much.
Absolutely. Thank you.